Well, in that case, may I suggest then that we move on to Alan Whiteside, who is also going to talk about money. And actually, there may be intersections here where the two of you may have questions and perhaps come back. So it's a huge pleasure to introduce Alan Whiteside, who's been thinking, speaking, reflecting, and working in the field of HIV for many, many years and has huge experience now from Ontario, who's going to talk to us about the implications of various sizes of investment. So, Alan, over to you.
Not a promising title for the last session of the afternoon, is it? Return on investment scenarios, mid, small, and large-scale investments. So I thought I'd try and talk a little bit from experience, and I thought I'd draw on the characters from Winnie the Pooh in giving this final presentation of the day. Because I think when we talk, and I have to say that I've come to this presentation having changed my mind over the years. 5 years ago, I would have said no. Let's not go there with rolling out antiretroviral therapy, and with good reason, I might say. It was John Maynard Keynes, the famous economist, who said, when he was challenged because he changed his mind, someone said, "But Mr. Keynes, you were saying this 5 years ago." And he said, "Well, when the facts change, I change my mind. What do you do?" So I make no apologies for changing my mind on this, but I go at it very, very cautiously. Because I think what we had effectively in this discussion around antiretrovirals were two extreme views. On the one hand, and for those of you who are not embedded in English children's literature, Eeyore is famously the donkey who stood in the thistle patch and said, "Oh, no, 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 it can't possibly work. No, no, not a chance." And on the other hand, there was Tigger, bouncing around, and I can see at least one Tigger in the audience who really did bounce around and say, "Yes, yes, we can." Self-identified now.
Yeah,
Thank you, Julio. So I think we have to look at this in some new ways, and one of the things I'm going to do is present you with a new way. So then I thought, well, maybe I need to deal with this question of return on investment that I've actually been asked to talk about, and talk about this issue of small, mid, and large-scale investments, and to understand what it is. And I did what every academic now does when faced with a conundrum. I went to Wikipedia and looked up return on investment. And there I discovered what it wasn't. Well, return on investment is something we all do, and it's about 2 to 3 years that people look, and they don't generally have a net present value. And as an economist, there are some issues with this. Because when we talk about HIV, we're talking about 10, 20, and now, as we saw from Badara's graph, 50 years of life of people on ARVs. And if we manage to get children onto ARVs, perhaps we're even talking about 60 years of life. So it's not something that lends itself to the type of return on investment thinking that we were asked to do it. And in case you don't believe me, have a look at this. It's not just virologists that can put up impenetrable graphs. Economists can bat with the best of them on this one. So then I thought about, well, what are some of the other tools that we might use? Well, economists like the concept of cost-benefit analysis. The problem with that is, if it doesn't work, it doesn't work. So if the costs outweigh the benefits and you go at it with an economic analysis, then you kind of have to accept that and say, well, we won't do it. That's the danger of using cost-benefit analysis. More appropriate in this context, and perhaps for this audience, is the idea of using cost-effectiveness analysis, which says we want to achieve a certain outcome, keeping people alive who are living with HIV, preventing mother-to-child transmission, within the resources we've had and the resources we can mobilize. What's the most effective way of doing that? And then, of course, there are a whole lot of other buzzwords which have been floating around and which people are using and that are out there, and they're all parts of the sorts of things that we can actually think about and use. And then I thought, well, actually, really, what you're asking me to do is that bit in the middle. But economics doesn't work that way. So then I thought, well, actually, maybe I need to go back to where I come from. Because I come from South Africa. I've lived there for 30 years. I wrote my first paper on HIV and AIDS in 1987. Unfortunately, before some people in this audience were born, I fear. We watched with horror as the epidemic spread through our society. We lived through the Mbeki years when the existence of HIV and AIDS was denied. And then I thought, well, maybe there's another way of looking at this. And I'm about to show you something which I tried out in a presentation in Cape Town in December. This is the second time I've given it to a peer group. I present these slides and I invite you, particularly you, Ruben, and anybody else who is mathematically literate, to take these ideas and run with them and see if they work. They're on the conference website. Here's an idea. Here's an idea. So, let's begin at the beginning. Let's understand the curves. And notice, please, that whilst I have numbers on one side, I do not have years on the other side. This is a very standard HIV infection curve. It's what we expect to see. Where are we? Well, it depends on which country we're talking about. This is a very standard curve which shows the deaths of HIV-positive people. Now, important caveat. Listen to me, listen carefully. I'm not talking about deaths from AIDS. I'm talking about deaths of HIV-positive people from any cause. And this graph shows you why you're not getting traction with ministers of finance in the developing countries. Because the area between those two lines is the number of people who require treatment. And as Badara and other people have spoken today, the number of people who require treatment is ever increasing. Those two lines don't cross. Therefore, the yellow area continues to increase. Now, if you're the Minister of Finance in Botswana, this is a worry. If you're the Minister of Finance in Malawi, this is telling you that donor dependency is something which will outlive you and possibly even your children. We have a problem. We have a serious problem in countries where we have this situation. There's another way to look at it. And I'm going to take you through a series of graphs here whilst I just quickly find my place on my crib sheet. So, what we have is the number of people who are living with HIV, who need treatment, is increasing because of incidence. The number of people currently receiving treatment should be increasing because we are initiating people on ART. If there's attrition from people currently receiving treatment, then the pool of people living with HIV will continue to rise. And of course, one way to move out of both pools is through death. So what we are trying to do, I believe, is two things. One is to reduce attrition, and the other is to reduce incidence. So then the question becomes, can we make a coherent argument about treatment as a way of reducing incidence, and how do we make that? Not to me, not to Julio or Badara or to Jane, but to the ministers of finance, the health planners, the politicians in the developing countries. So, here's an idea. When those two lines cross, you arrive at an economic transition. And this is something that has been well described by Mead Over, who was referred to a few moments ago, at the CGD in Washington. The economic transition occurs when the number of new infections falls below the deaths of HIV-positive people. And remember, not deaths from AIDS, but deaths of. And sadly, and I think we all recognize this, death is something we all face. Death and taxes. So we can look at these things and not say to ourselves, oh, death is a terrible thing. It is something which we will all face someday. So the moment we get our new infections below the number of AIDS deaths, and we can bring that orange line down, we are entering an economic transition. So I want to talk about an epidemiological transition, and my slide set is not doing what it should have been doing. So let me just flick through this for a second. Okay. So what I want to do is to add two more lines. The purple set of lines is a line which shows the number of new people needing treatment, which is obviously slightly below the number of new infections, although maybe it isn't if we move forward with the ideas that are being put forward today. And this model, this set of lines, is easily changeable, and somebody who's competent with maths and modeling can do it. And again, Julio, I look at the person you've got in your office who could do this. And the green line is the number of people being put on treatment year on year. And I'd like to suggest that we could talk about an advocacy transition, and we could talk about an epidemiological transition when the number of new initiations of treatment cross the number of new people needing treatment and the number of new infections. I would like to argue that you have an epidemiological transition when you have the number of new initiations of treatment crossing the number of people newly infected. And I would like to argue that we in the AIDS world ought to celebrate an advocacy transition when the number of new people needing treatment is exceeded by the number of new initiations. So effectively, we have two more transition points. We have an epidemiological transition point, and we have an advocacy transition point. So now we've got three transition points on this set of slides. Now, and I can't do this, but there are people in this room who can, and just to mention one name, Ruben and his team, and Debbie, maybe you could have some of your folk, like John Blandford, look at this. We can start playing with these figures. Because if we put more people on treatment, the number of deaths will start going down. We end up with a dotted line. If we put more people on treatment, the number of new infections will start going down. If we have those gains, then we can start putting even more people on treatment. And what happens? Well, the bubbles start moving. And so effectively what you're doing is you're preventing deaths, you're preventing them sooner, you're preventing new infections, and you're preventing them sooner. Isn't this an elegant way to look at the world? But that's just ideas. So we thought to ourselves, let's have a look at some real data. And I have to say, I'm not terribly comfortable with this part because I'm an economist, and it's quite possible I just assumed that I was right. But we did look at the HSRC data, and we did look at South Africa. And what we see here on this chart is real data HIV infections, real data AIDS cases, and real data AIDS deaths. And what we see here, when we look at new infections and AIDS deaths, is that gap I was describing a few minutes ago. This has to be a major source of concern for Praveen Gordhan, Jacob Zuma, and all the people in the Ministry of Health and Ministry of Finance in South Africa. It should be a real source of concern to anyone who is investing in South Africa's AIDS response, be it PEPFAR, the Global Fund, or whoever. The reality is that we have no economic transition on the horizon in South Africa. The burden the Treasury is going to have to bear going forward is going to continue to rise for the foreseeable future. This is not encouraging. So we said, okay, let's just run it again. Let's take our new infections, let's take our new infections minus the deaths, so effectively everyone between those two lines are the people that we actually need to treat, and let's put in the new initiations of treatment, and let's see what happens to the lines when we do that. And we ran it, we did this first in 2012, and we used the ASA model, which takes us through to 2025, and what we see there is potentially some good news. The number of new infections has actually exceeded the number of people on treatment exceeded the number of new infections minus AIDS deaths back in 2005. And that's something that maybe we should start shouting about and celebrating. So we arrived at our programmatic transition, I think, in 2005, just at the end of the Mbeki era. But he wasn't responsible for it, let's be clear on that. I think we've arrived at our epidemiological transition perhaps in 2009. I think that what we can see is that that gap is closing, but it's closing very, very slowly indeed. So there are the challenges that I believe that we face, put forward on a simple set of slides, which you can take away and play with. I believe that these ideas could be applied to any country with a halfway to decent data set. In fact, they could be applied to a city. And maybe, Julio, now that I'm in Canada, we could do it for Vancouver. But there are some caveats. And it would be remiss of me to finish this presentation without talking about those. When we talk about scenarios for this treatment rollout, I was told to think of 3 scenarios: small, medium, and large. And I think we've had those presented by other people during the course of today. The business as usual, or the let's go in there, boots and all, and try to deal with this epidemic, and things in between. Now, which scenario you choose will depend on these issues. The politics of a situation. Because if it's gay men in Uganda, frankly, you haven't got a hope. We're wasting our time. If it's drug users in Eastern Europe, again, I would say the same is true. So I think we have to get the politics right. We have to understand the budget. Are we going to get the resources? What is that convincing argument that we can make, as you have to do on the Hill, or to the Minister of Finance in Imbaban? Minister, do you want a new airport, or shall we treat AIDS patients? Oh, let's have a new airport. That's what the Swazis decided. It's easier to drive from Johannesburg. May I be forgiven for saying that, but if you're going to Swaziland, it's easier to drive from Johannesburg these days. So we have to think about budgets. We have to think about priorities. And again, I think we have to be realistic. AIDS is not top of the agenda. It is not the #1 priority. For those of us who have children, maybe it's environmental change that we're most concerned about. Maybe it's jobs. I think we need to be realistic. And I'm going to indulge myself because I'm ahead of time and just tell you how I came to this realization that we have to understand there are priorities. When I turned 50, I decided I was going to try some new things. One of the things I decided I would try to do was learn to surf. Not standing on a board, I'm too fat and unagile for that, but lying on a board. So I bought myself a bodyboard and I started going down to the sea and I started getting into the waves and I started trying to ride the waves in. It was decidedly difficult. It was a moment of humbling moment trying to learn to surf. But I did learn one thing. If I missed one wave, there was another one, and another one, and another one. And I ran out of energy before the sea ran out of waves. And I think that's something that we working in HIV need to think about. The wave of HIV may have broken on the shore. We need to think cleverly about what wave we ride next. I predict it's going to be climate change. HIV hasn't gone away. In Swaziland, it's horrendous. In South Africa, it's appalling. But if we're going to work in this field, we have to be smart. And maybe we have to start thinking about the waves that we ride in order to make sure that AIDS and health is the priority it deserves to be. And then there's the question of human rights. And we haven't heard a lot about that. But I go back to the gay men in Uganda and other parts of Africa and wonder why we don't hear more about this. We need to recognize, and this is from the National Strategic Plan in South Africa, that whatever we do is going to cost an awful lot of money. But it is clear that it won't be forever. And that graph begins in 2007. And as you can see, it starts at 10 billion rand, and it finishes in 2021 at a peak of about 40 billion rand. So we're talking about 4 times as many resources. And this is with donors who will have withdrawn. This is what we're looking for the National Exchequer, from the National Exchequer. So my challenge would be to help me make the convincing arguments that this is what we spend going forward. So my final slide. What do we need to think about? Well, I'm going to challenge you. I'm going to say, you've convinced me that treatment as prevention is important. But I'm going to tell you 3 things that you're not going to thank me for. No, 4 things, because there are 4 bullets on that slide. The first one is, it only works if you do it on a large enough scale. Sorry, guys, we have to get out there and we have to do it on a big scale. Second, you know what? We need to explain to the people we're talking to that this is bounded. We're not asking you to put money in forever. And we've started doing that, but we haven't got clever enough with that conversation. We need to be able to say, as we've seen on some of the slides, that our peak spend will be in 2020. And God knows it's getting closer and closer. So we need to have a clear time horizon. We need to be smarter. Sorry, we've become stale. HIV needs to get smarter. We need to find ways of communicating, of having moving bubbles on our graphs, of showing people what's going on. And we always need to say, where is that money coming from? Because if it's coming to HIV, it's coming from somewhere. So I began my presentation by starting with a few characters from Winnie the Pooh. You may ask me, who am I? Well, this is who I hope I am. Thank you.
Well, thank you very much indeed, Alan, for a really energizing presentation. And I can see, is that Dana with her hand in the air already? Hang on. Just a minute. Well, we've got a couple of minutes. We have some time left. So can we take a few points now? So we have Dr. Rosenfeld from Kiel. Can we keep them as precise as we can so that we can get as many voices as possible?
I will do my very best. I've heard, first of all, thank you. That was absolutely fascinating, Mr. Owl. I've heard a lot about modeling, a lot more, and I've learned a lot. But it seems to me, from a naive perspective, that all this modeling presumes a pretty stable geopolitical environment. And the only sort of changes that I've heard discussed over the last few days have been those in terms of medicine, which have been phenomenal, and those in terms of funding. But we're living in an increasingly fragile geopolitical environment in which stuff happens. Putin happens, Syria happens, ISIS happens, the privatization of the NHS happens. And you very rightly pointed to environmental changes, but I guess what I'd like to know is, how is the resilience of the systems that people are thinking about putting in place going to be assured so that when the next war happens, when the next economic blockade happens, these countries aren't going to be cut off and be able to independently produce these ARTs? I'm just worried about global fragility for geopolitical events, that's all.
Okay, global fragility, and actually, while the microphones, can we go over to Ambassador Birks as well? But do you want to make a response to that? Okay, let's have several together. Deborah.
So that was a great talk. Thank you. It's bad when epidemiologists start talking economics, and it's probably equally bad the other way. Because the only thing I warn you about, there is a standard epidemiologic diagnosis for when new infections and deaths cross, and that's the epidemiologic control part. Mead has taken that into economic transition because that's when your costs go down. But that is your epidemiologic control piece. Now, what we have found, and I think this is really important, I'm glad you picked up on it, about HIV people dying from non-HIV causes, because it's different in every country. South Africa's health system is actually quite good. So your rate of deaths is much less than Kenya, Tanzania, Uganda. And so prevalence, we've actually underestimated probably the number of non-HIV deaths. And that's resulted in us predicting epidemics that are probably prolonged and more costly. And I think we're really working on that side right now based on a Kenya model where we've done a lot of AIDS indicator surveys. So you can show that prevalence has gone down despite decreased HIV deaths from HIV, and you know that there has to be another contributor. So I think refinement of the actual data will lead us to refinement of models that apply to different regions of the country. But each country will be very different in that parameter. So we just have to, what Mead's definition is overlapping with the EPI definition. So that will make EPI people nervous if you.
And we have one other hand up there. Take this one.
Yep. What will be the role on your scenario of the impact of prices? Because outside South Africa, like for example in Mexico, the price they are paying for ARVs is like 10 times what South Africa is paying. But for politicians and ministers of finance in Mexico to break the rules of patents and go into generics, that will get enormous damaging consequences from the United States. The retaliation there will be immediate. So that means that the Minister of Finance doesn't want to touch that issue, and it's extremely costly. Right now, what Mexico is spending to cover around 30% of all people living with HIV, with the same amount will be covering close to 100% if they were paying the South African prices. So the impact of prices, I think, can be taken into account in your equations for other contexts outside South Africa.
Okay, thank you for those 3 points. Right, let's put those to you in the last few minutes that we have.
Right. I think the issue of prices is one which I obviously haven't considered. I think it's hugely important, and that's perhaps one of the reasons why coming to a meeting like this is so important for me, because I come from South Africa where prices are quite low, or Swaziland where they're even lower, and you're absolutely right. But my argument would be, if you're paying this amount of money for ART, then you are giving up other interventions that you could make. And maybe you could take those slides and just show if you can increase, I don't know if you're at capacity on ART treatment, but if you increase your treatment, then it does have that effect on everything else. So I think there is an argument for being able to do more with the same amount of money, or even more with less money. And it's appalling that you're paying those levels of prices, but I'm not in a position to comment other than to say that. I totally agree with Debbie. I mean, this is, but I'm not going to apologize for this little display of arrows and dancing bubbles. And one of the reasons is that somehow we have to get to people to make them listen. And if something like this, and I look at this audience, and actually, you know what? You're awake. Thank you. You have listened to this, and take it to pieces. Because I do think, and I also need to give a nod to John Blanford of CDC, who helped me with some of the thinking around this. I think we have to, this comes to my final point about thinking smarter and finding ways to advocate. it's so important that we find ways to talk that will reach the audiences we want to reach. The point about a model and the limitations of a model, absolutely. You know, as I said, I look back at where I came from in working in HIV and AIDS. I ran the first model that we ran in 1990. My God, we were wrong. So maybe what we do is we take another way of looking into the future, which is scenario planning, and use that in conjunction with modeling. And then you begin to be able to look at the cone of possibilities. And this is something which has been done quite widely, and I have been involved in it, and even UNAIDS tried to do it, but not very successfully about 10 years ago.
And any comment on the sort of global fragility, all the other things that are going on?
Yes, again, I have to say, again, something which one is deeply aware of. We wrote a paper about 5 years ago, and we looked at the floods in Mozambique, the public service strike in South Africa, and one other incident. And of course, you have to plan for it, but you can't plan for every eventuality, which is why I think you need to have your stockpiles, and then it gets washed away in a flood. What do you do? Ruben's got his hand up. Do we have at the moment, because he's the best modeler in the room.
Last word.
No, I wouldn't say that. But what I would want to say is thanks for the great talk. I just had a few thoughts on it. One is that I think it's pretty clear that we're going to see some sort of crossover point if you invest in ART expansion. Let me explain why. First of all, we're looking at health sector costs here, right? So we haven't really even thought about the societal cost, that perspective. And that perspective, once we start doing that, it's going to get enormous very, very quickly. And we're also really not looking at the individual costs either. So if you start adding those sorts of things into your calculations, all of a sudden it becomes very, very attractive. I think we're making a lot out of kind of something or nothing, and that is that insofar as that as you invest in getting people healthier, at some point you're basically going to, less people are going to be infected, less people are going to need ART. The people who are on ART, which you illustrated, are going to die eventually of either HIV or other causes, and you're going to be basically, along with other interventions, getting out of the epidemic, and your costs are going to go down. And they include staffing costs and all these things. So I think we're at the real basics in terms of the costing, but I'm very confident that we're directionally correct, and you're directionally correct in your graphics as well. So thanks.
Any last comments?
No, not from me.
So thank you to all the speakers this afternoon. A fantastic, stimulating afternoon. I think a well-deserved cup of tea before the final session at when do we come back? 4:30. So thank you all very much indeed.